Hi guys, good evening. Dr. Jenny here, physical therapist and doctor of physical therapy, creator and founder of Balance and Fall Support Group in Aging Adult and Physiogen PT and Wellness. I am a geriatric clinical specialist and also your state advocate here in Delaware for geriatrics, and also certified exercise expert in aging adult and the previous vice chair of global health in aging adult. So for tonight, we will have an interview for an amazing nephrologist. So every Thursday, we interviewed academician, instructor, and sometimes we even have some from Australia, physical therapists. We even have at one point in from London. Some of them are innovator. But for tonight, we have a great clinical nephrologist. We will love to learn more because in rehab, we have now some cases in our aging and older population having those dialysis, kidney failure, and it keeps growing, but we need to learn more. How it happened, what are the solutions, and as a therapist, what can we do to help provide education as well, for the family members and of course for the patient. And I am glad with his busy schedule, we have the opportunity to talk to Dr. Saez. He is a nephrologist for almost 20 plus years. He has a practice in Lewis, Delaware, We Care Nephrology, and he is also a consultant with multiple hospitals here in Delaware. We have also where I work in Bay Health, Sussex and Kent, and also in BB. So that's the southern part of Delaware. So if you're not familiar, because we are all over Dr. Saez. So without further ado, I would like to introduce to you Dr. Saez, and he is first of all Bachelor of Science from Delaware, and then graduated in Philadelphia for osteopathic, College of Osteopathy in 1997, internal medicine in Christiana Hospital, and he did his fellow in George Washington University Hospital. So that's amazing, and welcome, Dr. Saez.
Thank you for having me.
Yes, my pleasure. Did I miss anything, Dr. Saez, in my introduction?
No, it sounded perfect.
Yes, yes. So I would love to ask you, Dr. Saez. I know we met one of in the hospital. We have many common clients or patients, and then majority of course are kidney failure. They have patients with dialysis, but how much population nowadays did you notice the influx of these cases?
Well, there's a lot of in Delaware. There's over 1,000 patients on dialysis, throughout the state of Delaware, and the rate of chronic kidney disease is rising in the country. So a lot of patients, so they have diabetes, which is the number one cause of chronic kidney disease leading to dialysis. They also have hypertension, again, which is the second most common cause of chronic kidney disease leading to dialysis. Most patients have a combination of both. So we clearly see a rise in chronic kidney disease. Also with the rise in obesity amongst the young kids, we're seeing younger people requiring renal replacement therapy or dialysis. So renal replacement therapy is interchangeable with dialysis, so they're synonymous. So, but we're seeing an increase in younger population. Again, diabetes, hypertension. So these are the things that we really focus on to try to help reduce the progression of chronic kidney disease. And it would be great if we could just actually reduce or prevent chronic kidney disease altogether by controlling the diabetes and hypertension. Of course, there's other genetic causes of chronic kidney disease like autoimmune disorders like lupus. There's other genetic disorders like autosomal dominant polycystic kidney disease, which can lead to chronic, end-stage kidney disease as well. So again, these are the things that we see in our practice on a routine basis.
Yeah, that's really a lot. It's really challenging nowadays because we even have these patients in rehab, and at the same time, they're doing their dialysis. And we really notice the barrier that after dialysis schedules. We're doing a rehab, which we know that I'm working in acute rehab, which is 3 hours of therapy, inpatient rehab, 3 hours of therapy every day, combination of each disciplines, and then every day. So there's only one day off during the weekend. So what do you think will be, but I know it's case to case, right? Because some of them it's easy before or after. But in your practice, how did you notice? Are they like it's easier to see them before session, after session? What did you notice with these different patients?
Yeah. So let me just real quick just backtrack for a split second. You know, the vast majority of patients we see on dialysis are elderly population, patients greater than 65.
No.
So I don't want to sort of mislead, your audience to think that the majority of patients are young patients. The majority of patients are older patients over 65 years of age.
Okay.
But normally when I see the patients in rehab, we try to, if they're on hemodialysis, that's the blood type of dialysis, where they get dialysis Monday, Wednesday, and Friday, or Tuesday, Thursday, and Saturday, normally for 4 hours each treatment.
Okay.
We try to schedule dialysis on Tuesday, Thursday, and Saturday for most of rehab patients because a lot of times we don't want to interfere with their physical therapy and occupational therapy. You're correct. When patients receive dialysis, it's not uncommon for patients to be tired, a little drained after dialysis because we're doing a lot. A lot of people don't realize, you can be really tired after we remove 3 or 4 liters of fluid in a 4-hour period of time. It takes a toll on your body. Some patients remove 2 liters, but we can remove up to 4 liters or even more if they can tolerate it. So that really takes a drain. That really drains patients quite a bit and make them very tired and sluggish afterwards. Some patients have problems with dropping their blood pressure during dialysis. Again, that takes sort of a toll on them. Of course, there's all types of shifts of electrolytes, potassium, magnesium, calcium, phosphorus, sodium during these treatments, as well as alterations in their pH, body's pH, their acid-base status, as we call it. So there's a lot going on with dialysis, and so it's not uncommon for patients to be really, really tired and drained after dialysis. So we try to sort of adjust the schedule when they're on rehab to try not to interfere with physical therapy and occupational therapy if possible. Sometimes it's not feasible. And those patients, they tend not to produce, or I should say, participate as much in physical therapy if, after they've gotten their dialysis treatment. They're really sometimes just wiped out and they just want to go home or back to their room and go to sleep.
Yes, that's true. They're really exhausted. I even
Yes.
have some friends around me. They are like elders. I just surprised, but I have a neighbor at one point. She is more energetic after her chemo, and my other neighbor, she is really exhausted after that. So it's really surprising that they gave them more energy and then they're exhausted the next day. So I agree with you with those electrolytes, and they're monitoring their blood pressure, their weight during those visits as well.
Sure.
But yeah, let's go back, Dr. Saez, regarding the anatomy of those. So what is a normal kidney? You talk about something about the nephrons at one point. So why do we need to have this dialysis, their benefits for these patients?
So I always like to start off with my patients, let them know, because you try to educate patients. So what we monitor in the blood is called the creatinine. That's the marker of kidney function. For a woman, the creatinine should range between 0.5 to 0.9. That's the normal range for a woman for a serum creatinine. For a man, it's a little higher. It's 0.6 to 1.1. Men are, and that's in milligrams per deciliter. So men are considered a little more muscular than women on average. And your creatinine is produced by your muscle cells and it's released into your blood and it's filtered by the kidney. So if your kidneys are filtering out the toxins like they're supposed to, then for a woman, the creatinine should fall between 0.5 to 0.9, and for a man, 0.6 to 1.1. So what happens when patients have damage to their kidneys from diabetes or hypertension, or, God forbid, they're in the hospital and they're really, really critically ill and they're septic, or where they have an infection in their blood and they drop their blood pressure very low, certain antibiotics, certain chemotherapies, certain medications in general, it can damage the nephrons. And in each kidney, there's between 1 to 1.2 million nephrons. Nephrons are the filtering cells or the functional cells of the kidney. So when someone has an injury, when someone has an injury to their kidney, that those nephrons are damaged. So a lot of times if we see someone who has acute kidney injury, they're in the hospital, they had normal kidney function, and again, they're sick, they drop their blood pressure, or septic, or they come in really, really intravascular volume depleted or dehydrated, and they're on certain medications that can shut their kidneys down. The nephrons that die, they're gone forever. They don't regenerate. Mm-hmm. But what happens is that creatinine will go up in the blood because the other nephrons that are viable are sort of, for lack of a better word, sort of stunned, but they're still viable. So your creatinine will go above. For a woman, it'll go above 0.9. So you'll start seeing someone come in a creatinine of 1.5, 2, or higher. The higher the creatinine goes above the normal range, then out of 100% kidney function, the percentage of kidney function begins to drop towards 0 from 100%. So if someone's creatinine goes up to 2, then their creatinine, that's their serum creatinine goes above 2 or 3, out of 100% kidney function, that kidney function begins to drop towards 0. So we closely monitor that in the hospital. And hopefully by maintaining good blood pressure, stopping certain medications, if the patient's dehydrated, by hydrating these patients, their kidney function most of the time slowly recover. And most of the time go back to within normal range. But what we're talking about in the dialysis population, these are people who had diabetes or high blood pressure. And that's the majority of the patients, over 70% of the patients on dialysis because of diabetes and hypertension. Mm-hmm. These patients have had damage to their kidneys because of the high blood sugars or the high blood pressure, and that damage that's done is over time. So when it's chronic, it's normally irreversible. So when it's done over 10, 15, 20 years, the damage that's being done is irreversible. If someone comes to the hospital who had normal kidney function, they have pneumonia, and they become septic, their kidney function can shut down, and some of those patients may require dialysis, but that's an acute injury, meaning it's a recent injury, and the vast majority of those patients recover enough kidney function, even if they require dialysis, to come off of dialysis, and some of those patients even go back to the normal range. But the population we're dealing with, when we're talking about here, is patients who are end-stage renal disease who require dialysis. That chronic damage is irreversible, and what's happening is that the kidneys are unable to remove the toxins from the blood. So every day we eat, we have basic metabolic processes that go on, we produce toxins in our blood, and they should be filtered by the kidneys. Well, when your kidneys are damaged, you're unable to filter out the toxins in the blood, and those toxins build up in your system, which can cause symptoms over time. And those patients require dialysis. And dialysis is really just the artificial kidneys, a filter that can help remove those toxins from the blood. I had patients on dialysis tell me, "Doc, what are you talking about? My kidneys are fine. I'm making good urine." And so there are patients who are on dialysis who make over 1 liter of urine a day. And so your kidneys do more than filter out the toxins. They also make urine, right? So in that urine, you're supposed to have those toxins being released from the body, right, in the urine. But what happens is when patients are on dialysis and their kidneys those nephrons are damaged, the kidney is damaged, then those patients are unable to filter out the toxins, even though they're making urine. And so what we call that is an ineffective urine. Ineffective in the sense that it's unable to remove the toxins in the urine. So you're making water, which is good because it helps control your volume stats on dialysis, so we don't have to remove so much fluid on dialysis, but they still need dialysis. So even if someone is euvolemic, meaning that they don't have any extra swelling in their legs, they're not short of breath, they're making good urine, they still need dialysis because we still need to remove the toxins from their blood, irrespective of the amount of urine they're making.
Wow. That's really very clear for me now. So it's not always like when you say dialysis, oh, it's permanent, So it's like really like a treatment. I remember my mom, she had sepsis at 2 years ago. And then some of the doctors are thinking now to wash her because of those with dialysis. So we're thinking before, is it permanent? How long it will be? But it will be more on the AKI because she has an acute kidney injury at that point. Okay.
Yes.
Yeah,
And normally if someone has acute kidney injury or they have acute on chronic kidney disease and they require dialysis because again they're septic or they're really dehydrated, they have some type of flu or something, for instance, and they're not eating and drinking well, they have diarrhea, they're taking Motrin, NSAIDs, these non-steroidal anti-inflammatory drugs for arthritis. They're on lisinopril, which is a class of medication called ACE inhibitors or angiotensin receptor blockers like losartan. And so they come to the hospital and they're dehydrated, if they're on these medications, these medications actually prevent the kidneys from sort of maintaining adequate perfusion. And so your kidney function shut down, their kidneys will shut down. So those patients, acute kidney injury or acute on chronic, even if they require dialysis, there's a high likelihood that those patients will regain enough kidney function, may not go back to normal or their previous baseline, but they normally regain enough kidney function to come off of dialysis. So we normally watch those patients for up to 3 months. So even if you're on dialysis and you have acute kidney injury or acute on chronic kidney disease and you're requiring dialysis, we normally give you up to 3 months of dialysis and closely monitoring your kidney function for signs of recovery. Up to 3 months, we're cautiously optimistic that you will gain enough kidney function or regain enough kidney function to come off of dialysis. But after 3 months, we normally deem you chronic at that point in time, and really we're not optimistic that you're going to regain your kidney function to come off of dialysis. So normally 3 months is the cutoff. After 3 months, we sort of deem that we deem patients chronic end-stage renal disease.
Oh, okay, yes. So that's why I'm thinking, so when they're really very sick, they can be AKI, acute kidney, but they can develop, it depends on the comorbidities that they have, so it can be chronic. So how about the stages, Doc? We heard that stage 1, stage 2, stage 3, how many stages, and what's the difference between those stages for the kidney failure?
Right. So normally, a lot of people say there's 5 stages of kidney disease, but in actuality, there's 6 stages.
6?
Yeah, because stage 6. Well, let's just start with stage 1. So stage 1 is normally if you have normal kidney function or normal percentage of kidney function. So your percentage of kidney function is normally greater than 90%, but you have some protein or you have some blood in your urine, microscopic hematuria, or some protein in your urine. So that's stage 1, greater than 90% kidney function. Normally the creatinine may be normal. Your creatinine may be at 0.5 to 0.9 for a woman, 0.6 to 1.1 for a man. But again, you have some protein in your urine or you have some blood in your urine, some microscopic hematuria, right? So that's stage 1. Stage 2 is when you have between 60 to 89% kidney function. So you have between 60 to 89% kidney function. That's stage 2. Stage 3 covers a large territory. It's between 30 to 59% kidney function. So stage 3 is broken up into 2 stages, stage 3A and stage 3B. 3A is between 45 to 59% kidney function, and stage 3B is between 30 to 44% kidney function. Stage 4 is when you have between 15 to 29% kidney function. Stage 5 is when you have less than 15% kidney function, but you're not on dialysis. Stage 6 is when you have less than 15% kidney function and you're on dialysis.
Wow. So
Well, that's a
majority
lot to
of
try to
this,
remember.
yes, I'm writing. So it's more on the stage of the kidney function. That's how we grade the stage 1, stage 2. But did you notice if this on the stages 5 and 6, are they still functional, like mobile or?
Oh, yes. I mean,
Okay.
I had patients. So normally, if you're diabetic, when your kidney function reaches 20%, we normally start talking about what type of dialysis you want. And then when the kidney function reaches 15%, the recommendation is to start you on dialysis. If you're not diabetic, say you have only hypertension as your primary cause of end-stage kidney disease, everything is moved down for 5 percentage points. So instead of starting at 20% talking about what type of dialysis you would want in a diabetic, you would wait, if they're hypertensive only, you wait till they get to 15%, and you would start talking about what type of dialysis you would want. And then they would start dialysis normally at 10%. So, so everything is moved down 5 percentage points. It's the same thing if you had lupus nephritis. If you had lupus as a primary cause of your kidney disease or polycystic kidney disease, you start at 15% talking about what type of dialysis you want. And at 10%, you would then start them on dialysis. Of course, that's just the recommendations. Symptoms takes precedence over everything else, right? So I've had patients who are profoundly fluid overloaded and they're on high doses of diuretic therapy and they're coming in the hospital with congestive heart failure, or they have significant swelling in their legs, or they start to have weeping in their skins of their lower extremities. Even if those patients are at 18% and I can't control their volume status, I will start them on dialysis. So the percentage is only sort of a guideline, but if they're symptomatic and you can't control those symptoms, or say they constantly have problems with the potassium and really elevated, even with if you recommend dietary restriction of potassium-rich foods, or you may put them on medication that may help bring down their potassium, but if they continue to have problems repeatedly with high potassiums, you may, again, start them on dialysis a little earlier. The same thing if they have too much acid in their blood, if they have what we call a metabolic acidosis, and you have them on sodium bicarb tablets and they're just not, it's not improving and their acid level is pretty high in their blood. Sometimes you start those patients on dialysis a little earlier. But normally, if you're diabetic, you start at 15% on dialysis. If you're non-diabetic, you start at 10%. When I first started 21 years ago, I followed those criteria to the letter of the law. So I had patients who were diabetic at 15% kidney function who said, Doc, I feel fantastic. I'm making good urine. I feel great. So I would say yes, but the recommendation is I have to start you on dialysis because I need to make you feel better. And I feel great, Doc. But the recommendation is 15%. So I would start those patients on dialysis at 15%. After over 2 decades of training or practice now, I let those patients also train on the 10%. I don't start them at dialysis at 15% anymore because how do you know? We were always taught in fellowship, and during our training, you're going to make these patients feel better. But if a patient said they're eating well, they feel great. Some of these patients are exercising. Me starting them on dialysis is not going to make them feel better. So to me, like I said, so I tend to let everyone, and that's my own personal preference. I know the guidelines, but the way I practice, I let all my patients train down to 10%. 10% is my absolute cutoff because, again, if you're at 14% kidney function, 13% kidney function, and you're diabetic, and you tell me you feel great, then I'm not going to improve upon that with dialysis.
That's really good. I learned a lot from here. So for us to prevent these things to happen, to have kidney failure, so what will be your tips for us, especially our listeners? They are aging and older adults. What will be your tips for our clients or patients who are listening and the caregivers first, and later for a therapist standpoint?
Right. To me, again, if you look at 10 patients on dialysis, 7 out of the 10 are on dialysis because of diabetes and hypertension. Right. So diabetes and hypertension. So the other 3 would be, again, like these other conditions like lupus or some polycystic kidney disease or some other genetic disorders. So I would tell patients if they're diabetic and they're hypertensive, or they have one or the other or a combination of both, the most important advice I can give them is control their diabetes and hypertension.
Amen.
I mean, that's the most important advice. So normally, the family doctors, the endocrinologists, they like their hemoglobin A1C. That's how well you've been controlling your diabetes or your blood sugar over the last 3 months. They like that to be between 6.5 to 7. So that's, they consider that under good control for patients who are diabetic. For high blood pressure, the recommendation is a blood pressure of 130/80 or less. That's what we shoot for. So I had patients who come to me and they said, oh, doc, my blood sugars are 200 and my doctor, my family doctor is okay with that, or my endocrinologist is okay with that. I said, well, yes, if you were 400 and you're down to 200, then good for you. But at the end of the day, I want your blood sugars to be normal or as close to normal as possible. That's how you're going to prevent further damage to your kidneys. So to me, to have your blood sugars 160 consistently, you're not going to go into kidney failure and require dialysis within the next 1, 2 years, 3 years, but give it 5 years, give it 10 years, give it 15 years. It's going to catch up with you. The same thing with blood pressures. Oh, doc, my blood pressure is 142/91 or 182. My doctor said it's okay. I feel good. You want it to be normal because even those quote unquote sort of borderline numbers will catch up with you over time. Remember, disease is progression over time. So it catches up with you over time. So to me, the biggest thing is controlling your diabetes, controlling your blood pressure. A lot of our patients, elderly populations, they have arthritis, osteoarthritis. So, if you're taking a lot of NSAIDs, non-steroidal anti-inflammatory drugs, they got to be very careful. So the Motrins, the Advils, the Aleve, the ibuprofens, the naproxen, the Proxens. Some patients will take Celebrex. These medications, which is a COX-2 inhibitors, but the point is, it can actually, if you become dehydrated, it will work against your kidneys and shut them down. And especially if you're taking and you got to be careful because we have patients sometimes taking 4, 6, 8 tablets a day. Not only is that hard on your stomach and increase your risk of GI bleed, but it can also potentially contribute to acute kidney injury if you become ill, meaning dehydrated for whatever reason. So you got to be careful with that. One of the other things that I've been telling patients recently in my practice is, there's an antibiotic that's commonly used for sometimes for urinary tract infections, sometimes for upper respiratory infections.
Mm-hmm.
And the antibiotic is called Bactrim,
Yes.
Bactrim, Bactrim.
Mm-hmm.
And that's it's a good antibiotic. Don't get me wrong, it's a very good antibiotic. But a lot of the family doctors are unaware, a lot of the doctors are unaware that Bactrim can cause kidney failure.
Oh.
And a lot of times they put them on for 7, 10 days, sometimes 14 days, according to what the infection is. And they can actually go into kidney failure. The other side effect of that medication, it also can cause high potassium, sometimes a lethal range high potassium. So I've seen patients come to the hospital they've been treated for, a urinary tract infection or some type of sinus infection or some other infection with Bactrim for 10 to 14 days. And now they're coming to the hospital in kidney failure and dangerously elevated potassium. And it's all a side effect of the medication Bactrim. So I recommend to my patients, if they are placed on Bactrim, and I'm not, it's not like they're allergic to it. So I tell them, I say, you're not allergic to it, but if your family doctor wants to prescribe or another doctor wants to prescribe Bactrim, make sure they check your lab work, 2 or 3 days after starting Bactrim, and at the conclusion of the treatment course, making sure they check your kidney function, your renal function panel, so they can check your potassium and your creatinine. Because, like I said, if they don't know and the patients don't know, these patients can go into kidney failure, and they could have potentially a lethal outcome if the potassium gets dangerously elevated, because the normal potassium should be 3.5 to 5. Mm-hmm. But if you're taking Bactrim, sometimes I've seen patients come in over 6 or higher. And some of these patients are also on lisinopril, which is a potential side effect is elevated potassium. If they go into kidney failure because they're dehydrated or from the Bactrim, and they're eating, they're drinking orange juice, or they're eating tomatoes or potatoes or bananas, which are very potassium rich. Mm-hmm. Again, all these things contribute, and their potassium can shoot up dangerously high, and they can literally have cardiac arrest with extremely high potassium. So you got to be very careful. So just having that knowledge and understanding.
Wow, that's a great point. So I'm not familiar that the Bactrim has that side. I know GI bleed, but it's related with kidney failure. So these are lots of nuggets, Dr. Saez. Thank you so much. I know it's not only physical therapists are listening right now, but the general population. This will really helpful for them to know to take care of themselves generally more on to prevent further diabetes, take their maintenance, and also especially monitoring their blood pressure. So they will want it and check with their doctor, to take the proper meds, and at the same time do some exercise to be more active, and definitely, and maybe proper hydration before, and then to prevent this dialysis to happen, right?
Yes, I would tell patients when they go to their family doctors, write down numbers. Okay, write down numbers. So when someone says your blood pressure is okay, what does that mean? What does that mean?
Exactly.
So I've had patients, as a nephrologist, I'm a kidney and high blood pressure specialist. So when someone tells me, well, my doctor told me that my blood pressure was okay, I don't know what that means. I don't know what that means because
what is okay?
Exactly, because I need to know a number. I had a patient one time tell me that he didn't have high blood pressure, and I was seeing him in the office for the first time, and his blood pressure was 150 over 95. And I said, well, your blood pressure is very elevated today. And he says, well, this is the best it's been in the last 10 years. But he told me he didn't have high blood pressure. Yeah. So I'm thinking, oh my gosh, so get a number. So when someone says your blood pressure is good, what is that number?
Yes.
When you go to the lab or you go to the office and they say your kidney function is okay, what is my creatinine? Give me the value. And nowadays you're on my chart, so you can look it up for yourself and you can see, but get a number. Let me know what your potassium is. Let me know what the cholesterol level is and what it should be. Give me the normal ranges. And so we can now compare, because if it's elevated, then that should stimulate conversation. Why is my creatinine 1.5? And I will tell you one last thing. What most people don't realize is that you lose the vast majority of your kidney function with the early doubling of your creatinine. So if your creatinine for a woman is 0.5 to 0.9 is normal, when you go from 0.5 to 1, you're down to 50% kidney function that quick. So, and it's only 1/10 of a point above normal. So if you're at 0.5, because it all depends on where you start off. So the range for a woman is 0.5 to 0.9, but it's where you start off. So if you start off at 0.5 and you go to 1.0, you double, you're down to 50% kidney function that quick. If you go from 1 to 2, you lose half of your head. You're down to 25% kidney function. Going from 0.5 to 2, you're down to 25% kidney function that quick. So it's very important to keep a very close eye on things, because I've seen patients come to me and they're being monitored closely by their doctors, but their creatinine is 1.3, 1.4, and that, as though that's not bad, because it's, the range is 0.5 to 0.9, so that's not bad. But that person may be down to 30% kidney function in that range already. So it just depends. So you need to know the numbers of your creatinine, your percentage, your GFR, glomerular filtration rate, which is nothing more than a fancy way of saying your percentage of kidney function. So you'll see EGFR, estimated glomerular filtration rate, but it's nothing more than percentage of kidney function. So get those numbers. And if it's abnormal, you should ask your doctor why, and you should also inquire about, should I see a specialist, because I'm concerned if my kidney function is abnormal. Number one, why? And what can we do to prevent further deterioration of my kidney function?
Exactly. Yeah. It will be better for prevention, monitoring, and then maintenance to prevent more on the treatment itself, right?
Absolutely.
Yes,
Absolutely.
yes. Thank you so much, Dr. Saez. I learned a lot. Of course, I'm sure with our other therapists and other clinicians, these are very important for us, because these are the patients that we always see, patients with diabetes, hypertensions, and we definitely will educate them to be more proactive, communicate with their doctors, and monitoring their numbers, as what you've said. So guys, if you have any questions, you can connect with Dr. Saez. By the way, Dr. Saez, how can they connect with you?
Well, if they need to see me, if they're in Delaware and they need to see me,
Delaware.
right, in Delaware, right? My office number is 302-503-3922, or they could go to We Care Nephrology website, and they can connect through that. And if they have questions, one of the things I love about being a nephrologist and a physician is to educate people. I think the more you educate people, the better they can help themselves. And and it's a team approach. I can't do it for them, but they need me to give them all the information to inform them at a level that they understand. So I can speak medical jargon just like you could speak medical jargon, and you could be above most patients' heads. But you need to speak at a level that they understand, layman's terms, so they can truly understand what you're saying. And I always tell doctors, if you can't speak at a layman's level, then you don't have a good handle on what you're trying to convey, right? So you should be able to convey it at a level that anyone can understand.
Yes.
So to me, I like to educate, because once you educate patients, then they're better able to help themselves. And that's what it's all about, to make sure as a team approach that we're doing the best for the patients.
That's true. Better education, patient education is a great service for them. There will be a better compliance back home, because they understand, why do I need to do this? Why do I need to do therapy? Why I need to do the dialysis? What other things? Maybe I'll just do dialysis and do the other stuff by myself, But it needs, once they understand the importance of good maintenance at home on top of their dialysis and medications, that will be a great, outcome. So overall, thank you so much, Dr. Saez. We appreciate all your knowledge, and thank you guys for listening. If you have any questions, connect with Dr. Saez, and always connect with us with Physiogen and Balance and Fall Support Group, okay? It's me again, Dr. Jenny Yusuf, and we have Dr. Saez tonight. All right, bye guys. Thank you.
Bye.
Thank you, Doc.
Thank you.